thank you all again for being here and for participating in this very important discussion. And I'm going to spend a couple of minutes talking about therapeutics for COVID-19. And my goal is not to make you all treating physicians by any stretch of the imagination. That's not why we're here. But I think that is important for folks to kind of have a sense of what should be happening, because we know sometimes that when it comes, lots of research that has gone into health disparities and things like that, we know sometimes when it comes to being treated, we're not always considered for all of the therapies right off the bat kind of thing. So I want you all to be empowered to advocate for yourselves, advocate for your loved ones, and kind of have a sense of what's going on, because when you start to throw out those buzzwords, then providers take notice and they start to listen and consider what you're saying as well. So with that, we'll go ahead and get started. So just understand that disease can be caused in a couple of ways, right? So disease from the viruses or the negative clinical effects can come directly from the virus itself and how it infects the tissues and things like that. But it can also come, as Dr. Montgomery alluded to before, from the systemic inflammatory response. So that's kind of your body doing what it's supposed to do when it sees something that is not native to it. So it sees a foreign object, but sometimes that response can get out of hand and cause more tissue damage. So in light of those two pathways that you have to kind of disease is caused, you can look at treatment modalities from both of those measures. So with direct virus infiltrating cells, you can have antivirals that will attack the DNA or RNA replication or the cell's ability to replicate within the body. You can also have things like convalescent plasma and monoclonal antibodies that we'll talk about a little bit more, which basically also inhibit the virus from entering the tissues and being able to replicate as well. And when we're talking about those systemic inflammatory responses and the havoc that is reached there, we use anti-inflammatory medications for those. So I wanted to pause for just a second and talk about FDA approval versus emergency use authorization. So there's only one medication, and we've been at this for a year, and there's only one medication that is FDA approved to treat COVID-19, and that is remdesivir. And we'll talk about that in a little bit. But I think that's important because we're going to talk about several other things that are being used to treat the disease. And we'll also, touch on, people remember what happened with hydroxychloroquine, and there's some other things that have been touted down the pipeline in terms of vitamin C, vitamin D, all of these kinds of things. And when it gets to the point where things are being used at this manner, it is under emergency use authorization. So what that is, it's the FDA's way of allowing for additional therapeutics to be used. So it could either be a new drug or a drug that is already approved for something else to be approved for a particular condition when there is an emergency, when that has been shown, when the drug has been shown to have promise, and when there's not anything else available. And so what we had with this pandemic and this novel virus, we didn't have specific therapeutics to treat that. And we were experiencing lots and lots of deaths. And so people were trying things, just, what do we have in our toolbox? What can we do to potentially prevent people from dying or prevent people from being hospitalized, that kind of thing. And so what happens is studies are done. And when they start to show promise, you can petition the company that is making that drug or that device or whatever, can petition to the FDA and say, hey, we're showing promise in the research that we are doing. And so we're applying for emergency use authorization. And so that's what's happened. And that's what's happened with a number of therapeutics that are currently being used for COVID-19. And that's one of those things that happens with, that's happened with the vaccine as well. It is under emergency use authorization. And so I just wanted to make that point clear, because you might hear about EUAs and things like that in the news and not really understand what the difference is. With medications that are FDA approved, they've often had to go through a lot more extensive research before they get their FDA approval, lots of safety profiles and all of those kinds of things. And I'm not saying that the research is not there, but it's kind of a shortened track when they're going under emergency use authorization. And for certain drugs like the monoclonal antibodies, research is ongoing. So they're still in clinical trials with respect to those things. So just wanted to make that point about FDA approval versus EUA before we moved on. So like I said, remdesivir is the only drug that is FDA approved to treat COVID-19. And it's an intravenous drug that basically binds to the viral RNA and prevents its replication. So COVID-19 or SARS-CoV-2 is an RNA virus, and it replicates by invading the cell and replicating its RNA. So this drug prevents that. It is currently approved for hospitalized adults and kids over 12 years old. And it is approved specifically for hospitalized patients that require oxygen. And that's important. Well, I'll say it this way. So if you are getting admitted to the hospital, then someone should be talking about remdesivir. Admission patterns, I am a practicing emergency medicine physician, and as far as I know, things have not changed. But what we were doing with COVID-19 in terms of admission, we would admit folks that needed extra oxygen. So those are folks that were not able to maintain their own oxygen saturations at home at, greater than 94% kind of thing, 93, 94%. So it says to us that you need some supplemental oxygen. And so that would be a reason to bring you into the hospital. So my point is, if they're bringing you into the hospital, then you automatically meet criteria for to be considered for this drug. So if you are in the hospital requiring oxygen, ask about remdesivir. Some of the side effects are, GI symptoms, elevated LFTs, and there's some, which are your liver function tests, and some hypersensitivity reactions can occur. And it's not recommended for use in those who have severe renal impairment. So if you have severe kidney disease, that is something that you would need to talk to your doctor about for the cost benefit analysis with respect to this drug. This is an IV medication. It's administered over anywhere from 5 to 10 days. And so the initial dose is like 200 milligrams IV. And then after that, you get 100 milligrams every day for the next 4 days. If you're not showing any improvement, they can treat you up to 6 days with this drug. So with respect to convalescent plasma, so it's not so much the buzz anymore, but back in summer, it was kind of the rage. So the idea with convalescent plasma is that you can kind of offer this immunity, like this instant immunity to folks who have COVID-19. And conceptually, this is actually something that is very, very old. There was a gentleman by the name of Emil von Behring who got the Nobel Prize in Medicine back in 1901 for using serum therapy to treat diphtheria. So this is not a new concept. And basically, it's been used before in the first SARS outbreak, in MERS, H1N1, and also with Ebola as well. And so whenever we get this new in a new disease or a new problem, it gets dusted off the shelves and say, hey, can we use convalescent plasma to treat this? And I'll show you in the next slide why conceptually that makes sense. But there are several problems with it, in that, one, you never know how many titers, antibody titers, you need to use. You would think that it is most effective early on in the disease, because again, if you go back to thinking about the slide I had before, this is one of those ways to directly attack the virus and prevent its replication. And so early on in the disease, it would be one of those things that in theory would be very useful. The problem with COVID-19 is a lot of people are asymptomatic until they're not, right? So they've started to actually have a lot of viral replication, and then they become symptomatic. And so it's also unclear how long this immunity will last or how effective this treatment would be. So I just wanted to show this slide to kind of illustrate to y'all kind of what the process would be. So this is patient A who gets infected with COVID-19, and their body does what it's supposed to do. They build up their own immunity and they recover from it, but they have these antibodies to COVID-19 floating around in their system. And so then after that, they are able to donate their blood, and the blood is separated plasma, the whole blood is separated plasma and red cells. And within that plasma, you have antibodies now that the initial patient has created against COVID-19, and then you can directly inject those into patient B who is infected with COVID-19 and automatically give them immunity. So you're automatically giving them antibodies that can bind to the virus and prevent its replication. And so it helps, it augments the person's own immune system while they're having time to kind of ramp up on their own in the normal fashion. So like I said, that was kind of more the vogue back in the summertime, back in August or so, but there was an article published in the New England Journal of Medicine in December, I believe it was, that basically showed that there wasn't benefit between those that got convalescent plasma versus those that did not. And so people had, prior to this, and this was like the only randomized controlled trial in medicine. We like randomized controlled trials because you're asking a specific question, you're dividing people into two groups. One group gets the intervention, the other group doesn't get the intervention, so you can directly, and everything else stays the same, so you can directly decide whether that intervention is warranted or not. And so people had anecdotal information about convalescent plasma working, but nobody had done any randomized control studies. It was not clear what the antibody titers needed to be, when you initiated it, or any of those kinds of things. And so those are the things that a randomized control trial does. And when they put those things head to head, they saw that there wasn't really a benefit at 30 days. This particular study looked at a clinical benefit at 30 days, and there wasn't a benefit between group A and group B. So because of that, the side effect profile was very similar and those kinds of things. There wasn't enough information to recommend saying, hey, we need to use convalescent plasma. Additionally, if you think about it, you need patients. Well, we now have, a ton of patients that have been affected with COVID-19, and fortunately many that have recovered, but you need them to agree to donate their plasma. And there's also ABO compatibility that has to happen. So ABO meaning your blood type, all of those kinds of things have to go into play when you're administering convalescent plasma. So it's nice conceptually, but practicality for this disease, primarily because there's such a long period, a lot of times, of people that are asymptomatic, not necessarily the best thing for this disease. But from this, we move on to monoclonal antibodies, which have actually been shown to be really good for COVID-19. And so it's a similar concept of giving that passive immunity, but this stems specifically from it generated in the lab from animal cells, right? So they inject or inoculate mice or other animals, but usually it's mice, and have them generate the antibodies in the B cells, and they combine them with other cells and basically generate this antibody that is geared toward fighting whatever virus we're going to fight. So monoclonal antibodies, like I said, have shown promise with COVID-19, especially when they are administered early. So again, it's giving passive immunity, and it's designed to be an outpatient intervention to prevent disease progression. And so in a select group of folks, and the group is selective because, again, it's under emergency use authorization. So that's one of those things. When it's under emergency use authorization, there's specific criteria that have to be met in terms of people being able to have this treatment. And so you get it as an outpatient, you get it early, and it has been shown to prevent folks from going to the hospital. I can say that here in my role in the health as the at the health department, I have weekly calls with CEOs from across the state, hospital CEOs from across the state, and routinely asking them, how is this doing with respect to your admission numbers? And folks had actually started to see admissions go down. We as a state are doing much better now. Prayerfully, that trend downward continues. But even before we started seeing that big trend down, we noticed that folks that had had monoclonal antibodies were doing better and not getting admitted to the hospital. So the exact name of them is not important. Eli Lilly has this bamlanivimab that is a single antibody, and Regeneron has this combo that I'm not even going to try to pronounce, but it's both of those antibodies that are used to treat COVID-19. So it is done as an outpatient setting, but it is an infusion. So you go in, it's an IV medication, you go in and it gets infused over a couple of hours. We have it set up, or it's done in these infusion clinics just in case there is, an adverse reaction or that kind of thing. And so when we talk about who does it benefit? So the monoclonal antibodies are designed to be used in folks that have are at high risk for progression to severe disease. And so this is a nice little slide that kind of summarizes who those people are, and just pointing out stuff really quickly. Anybody over age of 65 is eligible for monoclonal antibodies, right? You don't have to have any comorbidities. We know that the elderly are particularly susceptible to bad disease and severe disease. So we want to make sure they're taken care of. Over here in this category, age 12 or older, if you have any of these conditions, so chronic kidney disease, if you are obese with a BMI of 35 or greater, we've seen that COVID-19 has more adverse effects on those obese individuals, folks with diabetes and who are immunosuppressed. So they are also, because they're at high risk for progression to bad disease, they're eligible for the monoclonal antibody. If you are in pediatrics and have these conditions such as sickle cell, also if you're obese, heart disease, chronic respiratory diseases, you're also eligible for the monoclonal antibody. And age 55 to 64, that age group with cardiovascular disease, hypertension, respiratory diseases like interstitial lung disease, pulmonary hypertension, COPD, any of those things, you're also eligible for monoclonal antibodies. So the idea, again, thinking back to how we're attacking this virus, you want to get this treatment early. So people that have been diagnosed with COVID-19, that's the time to go in and ask your doctor, hey, can I get the monoclonal antibody? Because I don't want to go to the hospital. I don't want to get super sick. So something to consider, and something to consider early on. Finally, the next thing is dexamethasone, and I think this is the last big category. And so this is moving to that second tier that I was talking about in terms of trying to stop some of those inflammatory effects on the body. So we know that the body is doing what it's supposed to when it attacks the foreign entity, but sometimes things get crazy with cytokines and all of those things that you don't need to know the terms of, but basically your body's immune system gets haywire and it causes more damage than help. And so dexamethasone is a steroid, which is an anti-inflammatory, and is the hope for that is that it combats some of that inflammatory cascade. So this is for patients specifically who are requiring increasing oxygen, right? Or requiring oxygen via high flow nasal cannula or non-invasive ventilation. So that's if you've seen those CPAP machines, if you're requiring oxygen delivered that way, you're also a candidate for dexamethasone. If for some reason at your facility, dexamethasone is not there, you just ask, what is the steroid? Because they can replace it with prednisone, with methylprednisone. There's different kinds of steroids all in the same class that will do the same thing. Because again, we want to try to prevent some of that crazy inflammatory cascade. So it is not recommended though, and the committee at the NIH that is looking at all of these treatment recommendations, it is specifically not recommended if you're not on supplemental oxygen. So if you are not requiring oxygen, it's not one of those things to go into your physician's office and hey, can I get some dexamethasone? It's not really indicated for that in this time. So with all of these things coming out, and I know, one of the frustrating things that a lot of clinicians have had, as well as lay people with respect to COVID-19, is that there's just so much that we don't know. And that can cause frustration because we recommend one thing one day, we recommend another thing another day. And I know that can be frustrating, but, and we all remember kind of what happened with hydroxychloroquine, right? Like I mentioned before, it was touted the big end all be all, yes, we're gonna use that, it's gonna stop COVID and all of those kinds of things, but found out through more studies that that is not the case. In fact, the EU, the FDA removed its emergency use authorization for the drug because the side effect profile was so great and it was not beneficial. So that's one of those that it's gone back and forth. And then over here, there's ivermectin that is being talked about now. It's an antiparasitic drug and people like to talk about it because it's used widely in developing nations to treat parasites and things like that. And the thought is, hey, maybe this works for COVID-19. Well, some of the data, it's kind of back and forth. There hasn't been that nice randomized control trial yet that says we should definitely use it, we should not use it. And so it's one of those things though, if people are on the vent and you're trying all you can to keep your loved one safe, it's something you can also approach your physician about and say, hey, what about this ivermectin? And like I said, there have been people that have been talking about vitamin C supplementation, high dose vitamin C, vitamin D, all of these kinds of things are out there. And unfortunately, we just don't have all of the answers, but at the same time, if it's not harmful, say like for vitamin C, and for most of the things that I've seen about ivermectin that hasn't shown harm, you can talk to your doctor about whether it's just worth it to go ahead and give it a shot, but we're not quite sure of its efficacy right now. So this is the last slide, just to kind of summarize what we talked about. If you or your loved one is diagnosed with COVID-19, you have one of two options. So you can be at home and manage your symptoms at home. And that means you're not requiring supplemental oxygen. So it's at that time that you should ask your provider about monoclonal antibodies. Again, for those individuals that are at high risk for progression to severe disease, definitely go get your monoclonal antibodies. The earlier, the better. Unfortunately, if you might need to get admitted to the hospital, you can be on the floor. If you're in the hospital, unless, again, people have changed their admission practices, I doubt it, but you need supplemental oxygen. So that's the time to ask about remdesivir and make sure that your doctor is talking to you about remdesivir. And if you're not getting remdesivir, you need to ask why am I not getting it? Why is my loved one not getting remdesivir? Dexamethasone can be added if your oxygen requirement is going up. And so that's kind of one of those signs that says maybe your inflammatory cascade is a little on fire. So oftentimes if you're having increased oxygen requirement, they'll add dexamethasone to the remdesivir. And then if you end up in the intensive care unit, again, you're kind of far down that inflammatory cascade. So really, 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 they like dexamethasone, making sure that that steroid is being used and that you or your loved one is being treated with that. Remdesivir can also be used at that time too. People that have needed to be intubated, if you come to the hospital, need to be intubated, they've found that remdesivir helps with that as well, so you're not too far gone, and you can also have remdesivir at that time too. So these are a few websites for additional information if anyone's interested, and that is my email address. If you have any additional questions that don't get answered tonight, feel free to reach out.